Okay, so one of the most important things to understand about a randomized controlled trial is intention to treat analysis. And what this means is once randomized, always analyzed. So if a participant is analyzed to a particular arm, well, every participant is analyzed to some arm, and they should be analyzed in that arm at the end of the study, regardless of what happens during the study. Okay, so here's the design of the diabetes prevention program study that we talked about, and people were randomized into 3 different intervention arms. The first one was a lifestyle intervention where they were expected to lose 7% of their weight and exercise 150 minutes a week of moderate level physical activity. And so they were given lots of education and support to do that, but that was the intervention. It was losing that much weight and having that much physical activity per week. The metformin intervention was to take a metformin pill on a regular basis, every day or twice a day. And then the placebo was the same. It was to take the placebo every day or twice a day, whatever the particular person was prescribed. Now, what happens, of course, is that people do not do what they're supposed to do. So, for example, in this particular study, the researchers calculated the number of people who actually achieved, let's just talk about the lifestyle intervention, who achieved the 7% weight loss and the 150 minutes of moderate level physical activity a week, and that was 50%. So 50% did not achieve the intervention goals, even though they were randomized to this arm. Now, of course, that's not really unusual. But the point is that the study is looking at this intervention, and if people actually didn't engage in the intervention, then you might think, well, then they shouldn't be analyzed because it's not a true test of the study. Similarly, metformin, 72% of the people, so 28%, did not take the pill as they were instructed. Okay, and that adherence was higher for the placebo, but there were still 23% that didn't adhere. Now, of course, in the placebo, it doesn't matter as much because it's an inert pill, but the point here is that you have these interventions, and at the end of the day, you're looking at the results and you're saying, oh, this intervention, i.e. losing 7% of your body weight and exercising a certain amount per week, is what reduced diabetes incidence. But we see that adherence is much lower than 100%. So intention to treat analysis means that what the analysis is looking at the effect of the intent to treat rather than the treatment itself, and that's why it's called intention to treat. So in the analysis of this study, all the people that were not lost to follow-up, okay, were analyzed as having this intervention, and similarly with these other groups. So you can do what's called post hoc analysis afterwards and look at to see whether the people who adhered to the intervention did better than the people who didn't. But that is a biased sample because then you have a selection bias. Okay, so let's talk about why it's a selection bias to only look at the adherent participants and not analyze the non-adherent participants, even though it seems like it makes sense. So if you look at, we're going to divide up the people who have been randomized into the lifestyle intervention, so it's roughly 1,000 people, and then, half of those, so this is about 500, were adherent and half were non-adherent. Now, the problem here is that what differentiates these people from one another? And is that something that should impact the outcome, that may impact the outcome? So the whole point of a randomized controlled trial is this randomization. And so what the randomization does is it eliminates any confounding variables that may differ between these arms. So it makes it so that every arm, people are equivalent except for the specific treatment that they're getting in the study, okay? So if you don't use intention to treat analysis, you're breaking the randomization. So all of the benefits and the strength of evidence that you get from doing a randomized controlled trial is eliminated because you've now broken the randomization. So look at this down here. So here are the adherent versus non-adherent people. Now, who is likely to be non-adherent? Well, we don't really know, but it's certainly possible that people who have, say, fewer resources might be less adherent because, maybe they can't afford healthier food, and they can't exercise because they don't live in a place that's safe to go outside and jog. So I'm making those things up, but the point is we don't know, and there's something that could be related to the likelihood of getting diabetes that makes people either adhere or not adhere. And similarly, this difference is actually statistically significant, even though it's fairly small, between the people who, the percent of people that adhere to metformin versus placebo. So something that's really important with drug trials is that if you only analyze the adherent people in a drug trial, add some pictures here, these people who are not adherent may be people who are getting bad side effects, okay? And so those people, that proportion of the population needs to be accounted for in the outcome, okay? So or those people may be people for whom the drug is not effective. So if you ignore these people who are non-adherent in your analysis, you are going to inflate the appearance of the effectiveness of the drug, okay? The drug's going to look more effective because you're basically eliminating people who potentially were not seeing the benefit of the drug or who had really negative side effects. So this is incredibly important and also often ignored. So it's amazing if you look at research papers how frequently people ignore this. That is, they only analyze the people who were adherent to the intervention. The other reason to include non-adherent people in your analysis is that gives a more accurate reflection of what you can expect from the treatment. So in clinical practice, there are also many patients who are non-adherent. So it's more realistic to include non-adherent patients. So another big problem in a randomized controlled trial, this is also true in a cohort study as we discussed, is withdrawal from the study. So with a randomized controlled trial, for example, you may get, and also with a cohort study, you may get differential dropout, withdrawal from different arms of the study, which would lead to a potential selection bias whereby, you're getting a certain type of person who drops out, and that dropout may be related to your outcome. So one thing you want to be sure, you want to know whether the withdrawal is equal across arms, so again, as we said, there could be something that's common across these people that withdrew that is related to, whether they'll develop diabetes. And so those people are now missing, and so your sample is no longer representative, and also your randomization is broken again. So this is a trickier problem because at least with the non-adherent people, if they come to their data collection visit, you can include their data. But if these people withdraw, like you can't reach them anymore, it's harder. So you have to spend a lot of money in studies and a lot of time to prevent withdrawal. And there are some ways that you can deal with it, like finding data from medical records. If someone drops out and they don't come to your visit, you can look at their medical record. You can also use the last observation that you have for them and use that as their final data point. But these are all problematic. So anyway, this is another study and another problem with an RCT and something to be aware of. So due to the importance of the things that I just mentioned, intent to treat, analysis, and withdrawal, recently a bunch of journals got together and decided that this is required, this consort, what's called a consort diagram, and in the publication of any trial. So every journal doesn't require it, but most of the good ones do. And so if you submit a paper that describes a trial, you have to include all of this information. And the reason is that this tells you what the extent to which you have some kind of selection bias in your sample. So you see here, it shows how many people were excluded before they were randomized, then how many people were allocated to the intervention arm, how many received the allocated intervention, and then how many did not and why, how many were lost to follow-up, and then how many were analyzed, and then you have to explain why people were excluded from the analysis. And now to get an ORCT published in a good journal, I think you have to have pretty good numbers here. So there's an increased recognition of the importance of these for the validity of a randomized controlled trial.